Morning.
And option next week will the weekly quizzes. Okay. We have continuation, exophytic, benign, soft tissue lesions. And like 2 weeks ago, I introduced the sort of epithelial base exophytic lesions. Remember that 90% of them were HPV induced, which caused the proliferation and pretty much involved proliferation of the epithelial, sort of stratified squamous epithelial layer. Obviously, there was one papillary sort of funky epithelial lesion that is typically the result of localized trauma. And do you remember the name of that activity? Starts with a V. What's that? I thought I heard something. Forms and inflammation. Okay, so today I'm going to go through some of the second cell proliferations that typically start within the submucosa, lamellopropia, and then finds its way through proliferation and still causes clinically an exophytic sort of dome-shaped lesion. In this case, we have sort of elements that are responsible for these benign lesions include fat, fibrous connective tissue, nerve, smooth muscles, striated muscles, all the elements you would typically find within the submucosal lamina. So rather than just hit you with, some seemingly arbitrary long list of entities, I thought maybe I could break it up into essentially 3 subcategories. We have the 6 P's. We have those that typically arise in the tongue and other areas within the oral mucosa. And of course, there are quite a few soft tissue proliferations that have a syndrome association. All right, so with these 6 P's, again, just want to come up with a few generalizations. They're not absolute, but they are pretty much good, good generalizations that you can kind of put up your hat, and it will definitely sort of help out with creating or at least coming up with a differential diagnosis. And so, as far as biologics, with your 6 P's, they're benign, they're either reactive or some type of true neoplasm. Most, as far as locations, most are going to involve the and may involve the skin as well. Shape, most of these lesions are going to have a dome shape, nodular architecture, either with a broad base or connected by a stalk, which would make it the key word, dunculated. Texture, most of them are going to be smooth surface, however, they can appear ulcerated and symptomatic. And the color ranges are going to be, or at least range from sort of mucosal pink to red to even pigmented. All right, so our first soft tissue lesion, the irritation fibroma or peripheral fibrous hyperplasia. Again, just wanted to let you know about the so-called P's. Irritation fibroma, however, it is also been referred to as peripheral fibrous hyperplasia or focal fibrous hyperplasia. Pyogenic granuloma, peripheral ossified fibroma, peripheral giant cell granuloma, paralysis, and peripheral odontogenic. So these are essentially your 6 P's. They're not the only entities that can appear as a gingival swelling. However, at least off the top of your head, you're thinking of a gingival swelling, you're thinking about a dome shape, intraoral proliferation. As far as the nine categories, these six should be easily recalled. All right, so irritation fibroma, the most common tumor of the old cavity, tumor in quotation marks. It's not truly a neoplasm. It is a reactive, or at least representative of reactive hyperplasia of the sort of fibrous tissue. Many instances, irritation fibromas could be the result of fibrous maturation of a previous lesion called pyogenic granuloma, and we'll go into that very soon. In most instances, irritation fibroma, the most common location is above the mucosa, especially along the bite line. Sometimes you can see them very easily closely associated with linea alba. These lesions are asymptomatic, middle-aged individuals, although they can be seen in just about any age group, but most commonly middle-aged, and there is a slight female predilection. Some of the other areas, obviously, any area that's going to be subjected to any level of irritation or trauma, labial mucosa, tongue, gingiva, and clinically with irritation fibroma, the surface will be smooth, mucosal in color, mucosal pink, unless of course the lesion is chronically traumatized. Then it may either present ulcerated as an ulcerated surface, or it may have an interesting sort of brownish pigmentation, or even sort of hyperkeratosis, therefore giving it a white appearance. Here's an interesting type of irritation fibroma, typically seen in the pediatric age group. This is the frontal tag, and it typically affects the maxillary and labial frontal. So for irritation fibroma, as far as treatment and prognosis, patients do well with conservative excision, and you'll hear this particular treatment throughout the entire presentation. Again, keep in mind, even though you may suspect that it is a benign reactive lesion, all of these lesions should be carefully submitted for histopathologic evaluation. As you'll see, many entities can mimic this sort of archetypal irritation fibroma. Myogenic granuloma, our next entity, tumor-like growth. It's non-neoplastic. Decades ago, it was theorized that myogenic organisms were responsible for these lesions, but it is now believed to be unrelated to infection. So again, with myogenic granuloma, we're looking at an exuberant sort of tissue response to local irritation, oral hygiene, or even fluctuations in hormonal levels. Clinically, these lesions, they're going to present as a sort of dome-shaped, lobulated entity. Again, because of chronic irritation, these lesions, especially from poor hygiene, localized or over production of plaque, calculus, even extended restorations, intracoronal restoration, or even coronal restorations can lead to the development of these lesions. Most of the pyogenic granulomas will appear on gingiva. However, there are some extra gingival pyogenic granulomas, again, those areas that are subjected to trauma. They typically have more of a lobulated, multinodular kind of appearance. So again, with pyoidal granulomas, you can pretty much tell early lesions, they tend to be extremely red, ulcerated, and they tend to bleed very easily. Over time, you'll notice that the lesions will become a lot more pink because they're becoming a lot more fibrotic, and over time they can pretty much take on the appearance of an irritation fibrosis. Because of the vascular effects of hormones, this particular lesion was used to sort of describe what's called the pregnancy tumor or granuloma gravidarum. And again, it's usually due to increased levels of estrogen, progesterone, especially as pregnancy progresses. And over time, these lesions tend to, over the course of pregnancy, they will increase in size. Aculous granulomatosis. This is just a fancy name for granulation tissue that sort of fills in the extraction site, post-extraction. And so in many instances, you will find sort of overproduction of granulation tissue. So aculous granulomatosis is something you will definitely see, especially in oral surgery when you're following up on your patients after an extraction. So again, conservative excision, patients do well. Make sure that the lesions are incised down to the periosteum, and make sure that the adjacent teeth or follow the scale that we're putting again, because we want to remove any potential sources of irritation. Our next P, peripheral ossified fibroma, relatively common. Again, certain researchers have posed the question as to whether or not these started out as IgA granulomas and just essentially developed, or at least developed more of a ossifying component, especially in the face of dystrophic calcification. Usually, dystrophic calcifications, it's usually associated with long-term inflammation. We have other schools of thought who, where they sort of consider the periosteum or elements within the PDL as sort of being the progenitor cells for the ossifying component of this lesion. Keep in mind, this is not considered the counterpart of the benign fibroosseous lesion that occurs within the centrally within the jaws of the ossifying fibroma. So with POFs or peripheral ossifying fibroma, they occur exclusively on the gingiva. They usually emanate from the entadental papillae, and they are frequently ulcerated. Teenagers are most commonly infected, and there is a slight female predilection, I should say. Slight female predilection. 2/3 of the lesions occur in the anterior jaws, more specifically the maxilla and the cuspid, inside the cuspid area. So at least histologically, you can see the sort of overlying squamous epithelium, and just underneath within the submucosa, you have this sort of interconnecting hard material. Under higher magnification, you can see that this is a sort of immature bone with lacunae, osteocytes within the lacunae, and this is the ossified component of the sort of peripheral ossifying fibroma. Conservative excision, submit for pathological examination, and again, especially with these lesions, we want to excise them down to the periosteum because they already come with a relatively high recurrence rate. On XP, the peripheral giant cell granuloma, relatively common, favored to be reactive in nature. Microscopically, they do have a very close resemblance to central giant cell granuloma. And some researchers believe that this is the soft tissue counterpart of the centrally involved or the intraosseous central giant cell granuloma. Another lesion that occurs exclusively on the gingiva portion of the alveolar ridge, especially the dentros alveolar ridge. Relatively small, most will be less than 2 centimeters, and these lesions will either be sessile or pedunculated. Keep in mind that with peripheral giant cell granulomas, for the most part, they tend to be more bluish, purplish when you compare them to your pyogenic granuloma or even your irritation fibroma. Typically, pyogenic granulomas are going to be fiery red, especially early on. So that's just one of the soft ways to sort of differentiate clinically between peripheral giant cell granulomas and pyogenic granulomas. When it comes to this entity as well, what's interesting is that the mandibular is favored, especially in the, it can be either in the anterior or posterior, but the mandibular gingiva is favored over the maxilla. And if the lesion is pronounced proliferative enough, it can cause a type of resorption in all of the sort of underlying alveolar bone. It's called cupping resorption, and sometimes it may be a difficulty differentiating whether or not the lesion originated in the bone and it's made its way through the cortex, or vice versa. So again, histologically, histopathologically, very similar to the sort of centrally intraosseous giant cell granuloma. And what we have is just a collection of these multinucleated giant cells that are all throughout this screen, and a background of monocellular cells and blood cells or erythrocytes. So this is a sort of classic picture of peripheral giant cell granuloma and central giant cell granuloma. So again, incision down to the one bone, scaling the adjacent tissue is very recommended. It's relatively high recurrence rate. So anytime these lesions occur, re-incision is recommended. There are particular lesions that are associated with hyperparathyroid condition. And so because the lesions, at least this particular lesion is very similar, on occasion, patients probably should be tested for any increase in parathyroid levels. Only on occasion. It's not a clear cut rule, but depending on how or at least what the patient's medical history is, it may be something to consider. You all know what the perilous, again, has to be mentioned, can present as a sort of alveolar or at least integral mucosal swelling, nodular swelling. This is also known as the gum boil. So you may have a few of your patients that may describe this particular entity as such. So again, with the perilous, we're looking at inflamed, sessile, accumulation of granulation tissue. These lesions tend to be very fluctuant, and it results from the accumulation of pyrolux from a nearby necrotic tooth. Okay, so occasionally, if there is a sinus tract, or at least if the purulence has made its way through the epithelium, gut puncture point may be useful in identifying the sort of culprit or the tooth question. Peripheral odontogenic tumors can present as a sort of a peripheral nodular lesion affecting the gingiva. Again, these lesions can mimic, you name it, in irritation fibroma to a pyogenic granuloma. However, histopathologically, they're going to look the same as the intraosseous component. Local excision is curative. Biologically speaking, these lesions do, at least patients do well with just a very conservative treatment. Some of the well-known entities of odontogenic tumors that can present as a peripheral odontogenic tumor includes the neuroblastoma, adenoid odontogenic tumor, pinboard tumor, and the peripheral odontogenic fibroma. All right, so moving on from the ERPs, we're going to now get into some of the more specific entities. This is the giant cell fibroma. Off the bat, know that this entity is not associated with chronic irritation or trauma. These patients, these lesions can end up just about anywhere within the oral cavity, but most commonly they do affect the mandibular gingiva. And what's interesting about these lesions is that sometimes they can be very, very papillary, at least on the surface. I have seen differentials that included squamous papilloma, condyloma acuminum. So just be aware that there is a sort of an entity with the word fibroma that can sort of present with a bubbly or oscillating surface. There's also a sort of interesting related lesion that occurs on the lingual gingiva of mandibular cuspids, the retrocuspid area. Just keep in mind that it's very, very similar histologically, and they tend to be bilateral as well. So again, histologically, you can see how the lesions are very, very oscillated or very bumpy, and how that could sort of infer this sort of papillary presentation. Within the lamellopropia, the giant cell fibromas, you have these stellate-shaped, very large fibroblasts. Hence the term giant cells. Patients do well when they're removed. Recurrence rate is pretty much close to zero. Epulis figuratum is another quote-unquote gingival tumor. At least the word epulis means gingival tumor, and figuratum describes the overall architecture of these lesions. They're very, very related to ill-fitting denture flags, either from a complete denture or a partial denture. And over time, you have this sort of fibrous epithelial proliferation that tries its best to fill in the voids between the mucosa and the dental flange. Over time, you have this redundancy of tissue that sort of occurs within the vestibule. So it's a linear hyperplastic sort of tissue that forms from those little dentures. There's even a sort of a related reactive term or a reactive lesion called the fibroepithelial column. And this essentially occurs under, once again, no filling dentures, but these occur on the hard palate. They're pedunculated, and you can see this very same lesion has been lifted from the underlying mucosa. It has a very serrated edge, and it also has been described as a leaf-like denture fibroma. So again, another type of epilous fissure that occurs right on the heart cavity. Histologically, you're going to see fibrous connective tissue, hyperplasia, and in certain areas you may see reactive bone or cartilage within these lesions. Patients do well after conservative removal and dental relines and adjustments. Patients do very, very well. As you can see here, this patient also presented sort of hyperdenture, redundant tissue that's located local to the alveolar ridge. And in this void or in this seam, this is where the sort of flange of the denture fit in. And so the tissue was removed, patients received the brand new denture, and over time that lesion and area, surgical area, healed very, very nicely. Again, just looking at the incidence of reactive hypoplastic lesions in the old cavity, interestingly, the majority of giant cell lesions. Very interesting how these compare to each other. This study was done back in 2019, 2018 in Brazil, and these were some of their findings for a 10-year retrospective study. Moving on to more denture-related reactive lesions, we have the inflammatory papillary hyperplasia. Again, poor-fitting dentures, especially in the palate, we have this bubbly, very, very bumpy, fiery red reaction to poor denture fitting and poor hygiene. Most of these, or at least 20% of these patients, will admit to sleeping with their dentures, wearing dentures 24 hours a day. And in certain instances, this type of reaction can also be at least noted in mouth movements for those very high palatal folds. So again, the lesions are very red, very, very papillary-like, very funky. Angry looking in certain instances. But again, once the edges are left out, hygiene is improved. In some instances, if you reline your denture, patients recover very nicely. All right, so here comes the mesenchymal cell proliferations. First, oral focal mucinosis. All right, that's a mouthful. I understand it's kind of like a weird lesion, but just keep in mind that this one favors the gingiva, second place guard palate, and again, these patients are going to present with sessile nodular proliferation. And basically, as the name sort of suggests, just underneath the epithelium, you have this sort of overgrowth of a myxoid fibrous connective tissue ground substance. In fact, there's a hyperproduction of hyaluronic acid in these lesions. This is incredibly benign. They don't recur after excision. So oral focal mucinosis, I admit it's a weird giraffe. But again, just something to keep under your belt. Oral lipomas, relatively rare in the oral maxillofacial areas. Just know that, like most lipomas, interestingly found in, or at least it's considered common in obesity. However, metabolisms of lipomas is completely independent of normal fat metabolism. So if you use caloric intake, it does not affect these liposomes. Liposomes will not decrease in size. Clinically, in many instances, they will display a yellowish hue, and just about any intraoral lesion can be integral anatomic site can be affected. Also, when it comes to buccal mucosal, buccal vestibular lesions, they may represent herniated fat pad, especially if there's a history of trauma to the face. But as far as the oral lipomas go, exceedingly rare recurrences, and again, these patients do well with local excision. Traumatic lymphoma, not a true neoplasm, it is the result of trauma. You will typically see these nodular lesions affecting the tongue or any area that has a high degree of or a high risk for undergoing some level of trauma. It is a lymphoma. Patients may experience pain. However, they may also experience a sort of burning sensation, can be intermittent or continuous. And again, these patients do well with conservative excision. This schematic is just showing how when a nerve, or at least in the case of traumatic trauma, when the nerve is transected, the body does its best to reoppose the proximal and distal ends, and they use the Schwann cells as a scaffolding or a sort of tubular template to grow or to direct growth of these neural proximal ends. Anytime there's an overproduction of scar tissue, usually those ends cannot meet, cannot mend, and you will get a sort of an accumulation of scar tissue and neural tissue. Neuroloma or schwannoma is a neural lesion. It is an actual neoplasm that favors the tongue, may be associated with neurofibromatosis type 2. Most of these patients will present with bilateral acoustic pneumomas. Schwannomas or neurolomas can occur within the jaws, but it's very rare. This is just to show you that it didn't occur on the tongue, it occurred on the lower lip. It does look, at least clinically, like a fibroblastic sort of proliferation, like irritation fibromas, the lower lobe. When this was examined, it's pathologically turned out to be a schwannoma. It's neurofibromatosis or neurofibromas, or a collection of Schwann cells, neurites, early fibroblasts. Again, they can occur both on the skin and intraoral mucosa, especially the tongue. They tend to be very solitary. Usually in young adults, they can occur within the jaws. But again, these patients do pretty well with excisional biopsies. Just want to make sort of add the syndrome component to neurofibromas when they're multiple, when they occur within the skin or mucosa. There is a type of syndrome called neurofibromatosis type 1. It is transmitted as an autosomal dominant, so it only takes one affected parent to pass on the sort of syndromic disease. And anywhere from 4 to 25% of these patients will have oral manifestations as the first sign. With neurofibromatosis, these patients, at least 5% of them will undergo what's called malignant transformation, and they will form malignant fibroblasts. So again, just looking at some of the lesions that are associated with neurofibromatosis, you'll notice even in the skin, and orally, these patients are presenting with multiple firm nodules of neurofibromas. Each one of these are neurofibroma lesions. In addition, they will also present with capital layer pigmentation. Very interesting sort of arrangement. Each one of these pigments have a very smooth sort of rounded border, as opposed to the capital layer pigmentations that are associated with McCooley-Albright syndrome, where the outlines are a lot more rough and irregular. Axillary freckles, these patients will present with hyperpigmentation and pigmented, discrete pigmented areas within the axillary. And again, just to show that these lesions can also present with sort of an intraosseous form of fibromas. It's very, very contiguous with the inferior alveolar canal. So the neurofibromatosis consensus around the world, they've come up with sort of a checklist of criteria for diagnosing neurofibromatosis type 1. And you'll notice that it ranges from 1 to 6. In many instances, if a patient presents with at least 2 of these criteria, they will be diagnosed with this particular syndrome. Sort of related, neurogenic genodermatosis that can be associated with particular syndrome is sort of multiple endocrine neoplasia syndrome. Especially pretty much in this syndrome, you have neoplasias or neoplasms or hypoplasias of neuroendocrine tissues. In type 1, you'll have benign tumors affecting the pancreas, adrenal glands, parathyroid, pituitary. What's very, very relevant to us is the MEN2B, where you have these patients will have mucosal neuromas, and they'll also have an increased risk for thyroid carcinomas and what's called adrenal field polycytomas. Transmitted autosomal dominant, at least 50%, the other 50% is representative of spontaneous mutation. Patients typically have what's called a morphinoid habitus. They have a very elongated face, protuberance all around and throughout the lips. Their axillary axial skeleton is very elongated. They also present with very elongated, exaggerated digits. And again, they will present with these sort of painless neuromas, mucosal neuromas that can affect the intraoral mucosa and portions of the skin. Lab-wise, laboratory values, these patients will present with elevated catecholamines, calcitonin because of the medullary and thyroid carcinoma. And again, just keep in mind that these lesions may represent the first manifestation of syndrome. So the earlier the recognition, the better, especially if the if these patients would undergo thyroidectomy, because unfortunately this form of cancer or this form of carcinoma affects these patients very, very early in life. Melanite, more normal T. That's a mouthful. Just know that this is one of the sort of neonate pediatric lesions that can present as a nodule, it can be pigmented, and it can cause bone destruction. And it's also considered a neuroectodermal tumor. So in many instances, these tumors have a sort of intermediate biologic, behavior. So just know that there's an increase in vanillin mandelic acid. That's another metabolite of catecholamines. So a lot of these patients will sort of present with this very interesting lab values. And here is just sort of a radiograph of this periosteal sort of proliferation of this tumor. And again, it will have somewhat of a sessile base, very large nodular lesion that affects especially the maxillary anterior maxilla. Granular cell tumor. One verification, you can find them on the palm. There may be multiple. The granular cell tumors were once thought to be sort of a derivative of some type of striated muscle, and they used to be called the myeloblastoma, but it's now been determined that these lesions are of Schwann cell origin. Okay, they're benign, and again, there is a female predilection. They can appear at the yellow lesion. In many instances, this particular tumor mimicked a salivary. The clinician thought this was probably a salivary stone, but it turns out it was a granular tumor. This is pretty much the classic presentation of granular cell tumor. Nodule, sessile base, mucosal color. And these tumors rarely affect children. As a matter of fact, what's interesting about the granular cell tumor is that the overlying epithelium, when viewed under a microscope, will present with this sort of pattern. And to the untrained eye, this pattern looks very worrisome. It looks like invasive carcinoma, but it's really called pseudoepitheliomatous type of ablation. And the underlying tumor, the granular cell tumor, sort of encourages or induces that type of overlying. So again, it may be one of those instances where you see an actual, you see an actual nodule, it looks benign, it's asymptomatic, and you get a pattern of what it says invasive carcinoma. Maybe maybe worth a phone call or even an invitation to the pathology laboratory just to go over the histopathology. So just know that something like a granular cell tumor can look very worrisome just watching. And as far as immunochemical or chemistry goes, granular cell tumors are positive. And again, these patients do pretty well with conservative excision. Apulus or congenital apulus of the newborn. This is a neonate, or this is a pediatric lesion that's sort of considered the granular cell tumor counterpart. These lesions only affect the alveolar ridge. And again, histologically, they kind of look like exactly like the granular cell tumors. It's just that you won't have the sort of overlying worrisome epithelial hyperplasia. Epithelium is relatively sort of a thin rim of epithelium as opposed to the granular cell tumor where the epithelium is all over the place. Within the heart of the lesion, you have these granular cells. But in the congenital apulus of the newborn, S100 immunochemical stain is negative. All right, so leiomyoma is just a benign tumor of the smooth muscle. Usually these entities affect the uterus, GI tract, skin. But as far as any moral agent, it's relatively rare. However, just keep in mind when it comes to smooth muscle, benign smooth muscle lesions within the oral cavity, 75% of them will arise from vessels. So most of these will probably be what's called an angiomyoma. All right, but again, clinically, it's going to likely mostly colored nodule. And again, some of the more common sites include the lip, tongue, palate, and cheek. Cards rated near zero, and they do well with circumcision. All right, so for our last one, rhabdomyoma. This is the benign neoplasm of skeletal muscle. So you have smooth, you have skeletal muscle, you have an adult form, a fetal form. And again, in both forms, the adult and fetal, there is a male predilection. And again, these patients do pretty well with just conservative medicine. All right. So please accept my apologies. I know that was a lot, but I think this is the best way to get through it. Because as you can see, a lot of these lesions have been starting to life, especially the ones we went over 2 weeks ago. And ultimately, yes, you will have multiple choice questions. Ultimately, you will have a slide component where you may be asked to come up with a different diagnosis. Obviously, you have clinical background information and medical information, even the laboratory items. Again, this is pretty much given like being prepared for your midterm, for your finals, ultimately for the field exams. So thank you.
Yes.